a really good topic. The ARRIVE trial and induction of labor at 39 weeks. Okay, so I took some notes because I wanted to spell this out in a very cohesive manner because I didn't want to go on a tangent. So basically the question was, and I hear this a lot, that getting induced at 39 weeks is being highly recommended and encouraged and pushed based on advanced maternal age alone. I just actually wrote a paper on this with my resident, and it's coming out. It's actually going to be a CME article. So as soon as that comes out, I'm going to talk about it. So, but I'll give you a little snippet. So let's talk about history. So historically, an elective induction of labor. What does that mean? Induction of labor meaning we bring you in and we start the labor process electively, meaning there's no medical indication, no maternal or fetal reason to start the induction of labor process. It's an elective induction. So it used to be considered that it was harmful. We should not be doing it because it's going to increase your risk of cesarean section. That's how I was trained way back when. And that it could be, you know, with cesarean section and increasing that risk and causing more maternal morbidity. But we've learned since then that that's not necessarily the case. We now know that inducing labor after 39 weeks does not increase the risk of cesarean. And one of the main trials was the ARRIVE trial, and my center was part of the centers in this trial. So it was basically a randomized controlled trial with comparing elective induction of labor at 39 weeks with expectant management among low risk, it's called nulliparous pregnant patients, which means they've never been pregnant before. Nulliparous means first pregnancy. So basically it compared induction of labor electively at 39 weeks versus expectant management. And this was published in 2018. The main thing they were looking at was whether or not there was an increased rate of cesarean delivery in either of the groups. But what they found that the rate of cesarean delivery was significantly lower in the induction of labor group than those who were expectantly managed past 39 weeks. They also found that the rate and risk of gestational hypertension and preeclampsia was lower in the induction of labor group at 39 weeks, as well as the need for neonatal respiratory support within the first 72 hours. So based on these results, the authors of the paper in 2018, which was a multi-center trial, actually, it was through the MFMU network, they aimed at the avoidance, so they suggested that policies aimed at the avoidance of elective labor induction among low-risk nulliparous, meaning first-time pregnant patients at 39 weeks, are unlikely to reduce the rates of cesarean delivery on a population level, which was a huge finding because we had traditionally been taught that you induce labor, you're going to end up in a C-section, and that is simply not true, okay? And also based on the findings, they felt that it was reasonable, and actually ACOG has supported this, that OBGYNs can offer elective induction to of labor at 39 weeks to low risk, nulliparous pregnant individuals because it doesn't have an increased risk of cesarean delivery and does not increase your risk of having adverse neonatal or maternal outcomes. And it also decreases your risk of cesarean delivery and gestational hypertension and preeclampsia. So what do we do with that? Now, this study is about low risk, nulliparous first-time patients at 39 weeks, but it kind of got extrapolated to everybody. At my center, we offer everyone an elective induction of labor at 39 weeks because my patients come from far away, and we offer that to them. Do they have to do it? No, they do not. But the general recommendation is if you start going past 39 weeks and you start hitting that 41-week mark, getting into the post-term, post-dates type pregnancy, then you might need to reconsider and maybe do some surveillance because the risk of stillbirth does start to increase every week after 40 weeks, okay? So that's something you need to discuss. This trial is not saying everybody needs to be induced at 39 weeks, nor is there any evidence that based on age alone that anyone has to be induced at 39 weeks. Now, if you're 39 and you're gestational hypertensive, diabetic, and you start what I call, how I teach residents, the red flags. I start lining up the red flags. How many they got? If it's just age alone, do I offer my patients that are 35 and above elective induction at 39 weeks? But I do, yes, but that's because I offer everybody that. But it's not because of their age alone. Okay, so I hear that a lot. You probably do too. Now, in my advanced maternal age patients, especially those over 40, do I start to get nervous after 40 weeks? I do. Because then you are starting to increase the risk of potential stillbirth. And I will say, you know what? If you don't want to do 39 weeks, I'll give you to 40 and let's reassess and make a decision because I really start to get nervous. And that's just me personally after 40 weeks. how do you handle those types of those patients, as far as especially those that are AMA and that's their only risk factor?
Yeah, so I like you, very familiar with the ARRIVE trial. It was going on when I was in residency at UT. So definitely I am an advocate for offering induction at 39 weeks to all patients. If they say they don't want it, which I do have like a subset of patients that are like, no, I don't want to be induced, that's fine. I tell them the data, let them make the decision and counsel them further. When it comes to AMA, because it's recommended, anyway, and even if it's a multip, you know, I do offer 39-week inductions for multiparous women. However, if they decide not to, I'm okay with that. Now going past 40 weeks, and 41, and I've had some patients that I'm like, okay, now this is making me anxious. You know, that's when, you know, we start talking about doing antenatal testing, and I actually ended up getting like an NST machine here to be able to do that, because I do have some patients that, you know, a little bit more granola, and they'll go to 42 weeks if they could. So, but yes, I do offer that for everyone. But if it's just AMA alone and they don't want it, I don't force it among anyone. But I do let them know, you know, that I do want to kind of monitor them a little bit closely. I'm seeing them weekly at that point anyway. So yeah, absolutely. But I have a lot more patients now, I feel like, though, in private practice than when I was in academic. More patients now that are like, I don't want to be induced. Like, I just want it to happen naturally. And, you know, even if they're 41 weeks and their cervix is closed, thick and high, they're just like, let's ride it out. And I'm like, okay. And I think the pandemic has changed things too.
So yeah, I'm on the opposite of the spectrum. Most of our patients want to be induced, and that's perfectly fine. But again, where our patients are coming from, a lot of them live far away, and it's just more of a peace of mind for them. That's just because of my patient population. But yeah, I offer, and all of us offer in my system, elective induction at 39 weeks. They do not have to do it if there's no other risk factors, no other complications. Basically, to summarize, telling someone they have to be delivered at 39 weeks based on age alone is not a recommendation. As long as everything else is okay, that's fine. But for me personally, especially as you're approaching the age 40 and above, I really want to get you delivered by 40 weeks. And that's usually, you know, I think how most people are doing, but you'll see it